look forward to, Gordon. I'd like to come
Yeah.
for a longer time than 2 days next time, you know?
Yeah. Next time, I hope you'll have a little bit more time because yes,
Oh,
Croatian
yeah, I'll
coast is
come for, I'll come
beautiful.
for a week. How about
Yeah,
that? I'll come for a week next
that's a good place. Yeah.
time.
See people sailing there. It's still
Yeah, it looks
summer.
beautiful.
Yeah.
Looks
It's one of the
beautiful.
magic parts of the Croatian coast.
Yeah, I'm sure.
Okay. So Aseem was supposed to lecture here at a TEMC conference, talk about the lifestyle and how we try to live healthier. But we already recorded one video on that topic. So maybe this is not what are we going to talk about. We are actually going to talk about this other really pressing item about COVID and vaccination. But as you all who are viewing know, we have to be extremely careful what are we saying because there is a very stringent censorship on many platforms, and we don't want to do things which are not allowed because then we won't be able to discuss things in open anymore. So if you think that some of the things we say are kind of self-censored, yeah, we have to do it at the moment. So Aseem, you've been so much all around the media in the last few days. So we didn't have, actually none of the Croatian press covered anything that you said. So maybe you can just start with the introduction about these two papers which you published, and then we can go on and discuss it further.
Yeah, thank you, Gordon. So there were two papers that were written that were published simultaneously in the International Journal of Insulin Resistance. And I spent probably a good 9 months from when I conceived the idea of writing the papers to them actually being published, because, as you know, Gordon, with medical journal papers, it can take quite some time. But I think what added more time to this is that it was very long. So it's two pieces that are about 5,000 words each, or 10,000 words. And the peer review process as well was very rigorous. So, you know, it went back and forth a couple of times at least with the peer reviewers.
Yeah.
So
maybe we can clarify something here, because I've heard people complaining that you have published in a paper where you are one of the editors, but as an editor, you do not edit your own paper. So somebody else chose the reviewers.
Of course
yeah,
not.
You know, we have to clarify to the people who are listening.
Yeah,
so you had nothing to do with the editing and peer review, right?
To be honest, Gordon, let's be honest with this. All right, there's a much bigger issue here at hand, which is even these this sort of stuff, these sorts of accusations or criticisms are coming. They're fueled, whether people know it or not, from the very industries we're attacking. Okay, so if the best they've got is to say Aseem Malhotra peer-reviewed his own paper, what that tells us is we're winning. We're winning the argument, right? So my association with that journal is very honorary, right? I don't edit any of the publications in there. It's just part of an editorial board to decide decisions on the direction of the journal, that kind of stuff. It's a very loose association I have from that perspective. And the second thing is, yes, I mean, obviously, I know some of the people there, but you know, the editor has to send these things for rigorous peer review, and it's been peer reviewed, and the facts are there, and people can read it themselves. So, and of course, there's no financial interest for me at all. I don't get anything financially. If the journal does well, I don't benefit financially in any way, shape, or form. Neither me nor an institution, anything affiliated with me gets benefit from that. So, there is no conflict there whatsoever. The reason I chose that journal, that's important. Let's just, before I talk about my findings, somebody asked me, Steve Kirsch asked me in America, he said, how many journals did you send this paper to before it was rejected? I said 0. I didn't send it to any other journal. This is the first journal I sent it to and the first one that accepted it. But I chose this journal for 2 reasons. One is, unlike many other medical journals, and this is all written about in part 2 to some degree, unlike other medical journals, this journal does not take money from the drug industry, okay? Because the real problem, the root cause of this crisis is a machine, like many big corporations, that is money extracting, anti-human and psychopathic, okay? And that they've got too much control. So I chose this journal because 1, it doesn't take any money from the drug industry. And 2, it allowed me to write 10,000 words. Gordon, how many papers have you been part of publications, or do you know of, that have 10,000 words? It's unheard of. I felt I needed to write that much because it wasn't just going to the science of the mRNA vaccines in terms of benefits and harms and breaking it down. It was when people get to the end of that part one, there's an element of, oh my God, you know, how do we get this so wrong? And the part two is actually going into the structural drivers, the system failures that led to this problem in the first place, which in many ways I've said was all predictable because we've not tackled these system failures for a very long time. So the part two is explaining, so part one is the science of the vaccine, part two is how did we get it wrong? Why did we get it wrong? And also solutions. I'm not there just to point out the problems. I'm saying here are some very clear solutions moving forward to change the system so that it works in the interests of the public and for patients and for, in fact, for doctors as well, for everybody. So that's what I did. And that's why it took a long time. That's why it's 10,000 words. But coming back to your original question. So the title of the articles, and also it's open access peer review. People don't have to pay for it. I want this, you know, knowledge should be that I certainly, everything I'm involved with, I ensure that it's open access. I tell the journals I don't want this to be paywalled. So it's free and open access. And it's called Curing the Pandemic of Misinformation on the COVID mRNA Vaccines Through the Principles of Real Evidence-Based Medicine. Okay? And that's the title, part one and part two in the Journal of Insulin Resistance. You can Google it, look it up, people can read it. So what were my findings? Well, I'm somebody that's been a very big advocate over the years for informed consent, something called ethical. It may sound foreign to some people, but I think when people break it down and understand it, they'll be like, okay, that makes sense. I'm a proponent of something very controversial. Are you ready? Ethical, evidence-based medical practice.
That's very controversial, yeah.
Very controversial. It is. Clearly, it's very controversial because my article is causing controversy because that's what it's talking about. And actually, the reason it's causing controversy is actually a very good symptom to some degree of the fact that we are not adhering. We're not practicing ethical evidence-based medicine in many ways. Not deliberately because of doctors not wanting to do so, is because they don't understand that the information that they get for clinical decision making is often corrupted by commercial interests. So,
yeah. So maybe, maybe we can explain the things because, you know, we know how it works, but people who are listening to us do not actually understand how do medical practitioners, so doctors working with patients, get their information. So how do they learn about the new drug? Who gives them the information?
Great question. Let me answer it indirectly first and then answer it more specifically. So as a patient, and we're all patients to some degree at some stage in our lives, right? So even I look at this from a perspective of being a doctor, but also a citizen and a patient. So that's the lens I write this from. And when our purpose as doctors, as healthcare practitioners, and what I'm sure our patients would agree and hope this to be the case, is to improve patient outcomes, right? So what does that mean? It means relieve suffering. It means managing risk factors. It means treating illness. Okay, those are the three broad areas of improving patient outcomes. But to do that, there are three components that are necessary for that purpose. And this is from an analytical framework for teaching and practicing medicine called the evidence-based medicine triad. It's beautiful. I love it. You know, this is the principles by when I manage all my patients, I think about this. So the three components are your individual expertise and clinical experience, the best available evidence about any intervention, whether it's a drug, whether it's an operation, whether it's managing heart disease, whether it's managing arthritis, whatever, okay? And then last but not least, Gordan, is taking into consideration individual patient preferences and values. The same information given to two different patients may result in two different decisions, and that's fine, okay? But that's crucial. It's about informed consent. So what's the problem with that? So if anything goes wrong with those three components, you're going to get suboptimal outcome for your patient, for you. You're not going to be managed in the best way possible, or it could do harm. So at best, you're going to get suboptimal outcomes, and at worst, you can do harm if there is a problem with any of those three. And the problem is we have an issue with all of those three, but in particular, the best available evidence, historically, certainly in the last 20 years, much if not most of the published research is essentially unreliable, low quality, false, etc. Specifically into the exaggeration of the benefits and safety of medications. Let's talk about that to answer your question. And then, of course, for patients, once that information is then broken down in the best way possible, from the doctor's perspective, it then has to be translated into a way that patients and members of the public can understand so they can make informed decisions. So the scenario, let's say for the vaccine is, have the vaccine, it's going to save your life, it's going to protect others. And that's been essentially the narrative, hasn't it? From the beginning, from the rollout, okay? And to not have it makes you at risk of having more serious complications from COVID, which may be true, but I'm going to break that down in a minute. And or you're failing to protect your community, and therefore you are a selfish person, you're an anti-vaxxer, you know, all sorts of nasty things have been thrown at people who refused or were hesitant of having the vaccine, okay? So I wanted to cut through all of that information and say, okay, in keeping with the principles of evidence-based medical practice, can we, at the very least, break down the information and help people understand what are the benefits from the vaccine for them as individuals based upon their age, okay? And what are the most likely harms in absolute terms based upon the best available evidence we have, okay? All scientific evidence evolves, nothing's perfect, there's always uncertainties, but we have to go with the best evidence we have. So let's talk about benefits first and foremost, Gordan. I'm glad that you said, of course, this isn't a posting or a discussion that's going to get us censored on Facebook. Who knows, or if that's going to happen. Maybe it will happen, but let's try and break things down. We're not saying don't take the vaccine. We're saying what does the evidence tell us? So what I did, and through the peer review process and working with data scientists as well, is we looked at real world evidence from the UK during the Delta wave last year, where we have a whole wave where we can look at a wave of COVID, the Delta wave, over a 4-month period, and to calculate, looking at vaccinated versus unvaccinated, what was the benefit of the vaccine in preventing people dying from COVID? Let's talk about that first and foremost as a hard outcome. I know people talk about other things like long COVID, whatever. We don't have any good quality evidence, but we do have some reasonably good quality evidence on preventing people dying from COVID. Now, the figures I'm about to tell you are still likely an exaggeration of the benefit because the data we have doesn't correct for baseline differences in vaccinated versus unvaccinated other than age. So for example, we know that people who are unvaccinated tend to be from lower socioeconomic backgrounds and actually may be higher risk from COVID anyway, which means the benefits of the vaccine when you're comparing vaccinated versus unvaccinated are going to make the vaccine look better than it truly is, okay? So let's just park that for a second. If we don't take that into consideration, and you look at age groups, during the Delta wave, okay, this is a conversation which is hopefully understandable for people, you know, when I have conversations with patients about other things, blood pressure pills or statins, this is how I break it down for them. For the people over 80, looking at vaccinated versus unvaccinated, you have to vaccinate 230 people to prevent one of them dying from COVID, okay? If you're over 80. If you're 70 to 80, 520, all right? Now, that was during the Delta wave. Once you get under 70, you then have to vaccinate at least 1,000 people, going into tens of thousands as you get younger, to prevent one person dying from COVID. What about Omicron? The current circulating strain is Omicron, which has been likened essentially to be as no more lethal than the flu, a bad cold or the flu, which is great. It's reassuring. We should be reassured. As Joe Biden said recently, the pandemic is over. Based upon that information, we should be reassured. What about Omicron? How useful is a vaccine for Omicron? And by the way, the new bivalent boosters are going to be no better, by the way. It's the same technology, and that's why it's important. There's no difference here. Looking at UK data from beginning of this year, during the winter, essentially, you have to vaccinate 7,300 people over the age of 80 to prevent one of them dying from COVID. That's, again, likely best case scenario. So we've got some information there that's useful. There's definitely an evolution for people to understand the benefits of the vaccine. One other thing before I tell you about the harms, or what we think to be the absolute benefit, harms at the moment. And again, probably an underestimate, but I'm going to give you on the best quality data we have what that estimate is. Some people may be watching, say, hold on a minute, what about antibodies? I had antibody tests done after the vaccine. I had antibody tests done after the vaccine. I thought, great, it works. For some reason, not fully understood, antibodies that are tested from this vaccine are not of any significance, do not appear to offer any reliable evidence in terms of benefit from protection or immunity from COVID. This isn't my words, Gordan. This is the FDA. This is on the FDA's website from last year. I've cited it in my paper. People can look that up. Basically saying the antibodies are not useful, reliable marker for protection, either from immunity from COVID or protection from COVID-19. And they said specifically after the COVID-19 vaccines, right? So what's going on? This is not science. I have no idea what's happening here, right? But let's come on to the harms, and then I want to again hear your perspective on this.
So before you go to the harms, I can add you something from my field. So what seems to be happening is that when you use mRNA vaccines, but probably also with the adenoviral vectors, is that this S-glycoprotein, the antigen of a virus, is being produced all around the body in different cells and different tissues. And our immune system gets confused because probably for the initial vaccination, this was not happening that much. But what we are seeing now more and more with the boosters is that our immune system starts to think these are the self-antigens because they're being produced everywhere. So if you have antigen being produced everywhere, and then these antibodies get a different glycosylation. And glycosylation are the regulators of the effector function of antibodies. So one way is to silence the antibodies is to put glycans which are preventing activation of the inflammatory response to the antigen. So something what I'm really careful about when we are talking about this new vaccine technology is that we might actually be confusing the immune system and making antibodies which are there, but which are not activating effector functions, meaning they're not eliminating the infected cell. So I'm quite concerned about the data coming out from some countries that now we have vaccinated people being infected with a higher frequency than unvaccinated.
Yes, Gordon, and I think that you're not alone in this because there is already some evidence suggesting, you're absolutely right, that certainly with frequent boosters, it could be causing an immunosuppressive effect. And we see surges in COVID after people getting vaccinated as well. So you're absolutely right. There's a lot of unknowns here. And of course, this is very concerning.
Yeah, but I don't know. I think also we should be rational in saying, it's not that people are getting totally immunosuppressed, that they're now going to get all the diseases and so on. There is no evidence for something like that. So the only evidence we are seeing at the moment is that actually antibodies against COVID do not really attack the virus that much. So, people who were vaccinated, and you was vaccinated, I was vaccinated, we were not damaged. Some people are afraid that they were damaged because they were vaccinated. So there are risks, and you will now start talking about the risks. But I think it's also important to count the people and say that if they were vaccinated, nothing horrible happened. If it happened a long time ago, there is no permanent damage or something like that.
Yeah,
so I think we have to be clear here.
Yeah, I think I agree with you. I think we need to reassure people. But at the same time, I think we have to be honest that there are, as with anything in medicine, there are uncertainties. So the one thing I would say, I think you're correct, that, and people should be reassured who've been vaccinated, that, and I agree with this, the most likely serious adverse events appear to happen in the first couple of months. So if you've not had any issue in the first couple of months, you're probably fine. Probably, okay?
Most of the people are fine.
With one exception, and that's where I come in as a cardiologist. My dad suffered a sudden cardiac death 6 months after the second dose. And his post-mortem findings did not make sense to me until, which we now have mechanistic evidence, and backed up with some data, both from Israel and certainly data over here, that one of the mechanisms of harm is that the vaccine, mRNA vaccines, could be accelerating coronary artery disease through a process of chronic inflammation. So that is the only thing where I would say, and if this is true, it is likely we will continue to see a surge for many years in heart attacks. And I'm pretty confident that that's a very plausible scenario. But everything else, absolutely right. And I think the other thing to mention is when you look at so people are, why did I not, I was on Good Morning Britain reassuring people that it was unlikely, that I didn't even conceive of the possibility, Gordon, that a vaccine could do any harm. Traditional vaccines are very reliable and safe. At that stage, I didn't know that they go through safety checks for 5 to 10 years. I'm not a vaccine expert, I'm a cardiologist. And obviously a lot of us didn't know about this technology. Even Robert Malone, one of the co-inventors of the technology, took the vaccine. So a lot of people didn't know what was going to happen. But now we've got evidence to suggest, for example, that the spike protein, instead of staying in the muscle in the arm, appears to be distributed in every organ system in the body for up to 4 months. And that's one of the possible mechanisms that the vaccine may be causing harm, either through direct cell toxicity or autoimmune or inflammatory conditions.
And there is another thing we should mention here. So many of my colleague scientists, they would say, mRNA has a very short half-life. But we have to be aware that this is a modified mRNA. It doesn't have a normal backbone, so it cannot be cleaved with the normal RNases. And this was made specifically to last longer. And unfortunately, we do not know how long and how much this varies from person to person. So this is one of the big unknowns we have to be aware of. And you probably know a couple of days ago, there was a paper showing that even in a mother's milk, you can find the vaccine a few days after vaccination. So, if it gets to milk, yes, it gets everywhere.
Yeah, absolutely. So then let's break down the harms. You're right, we need to reassure people as well. And I think that it's fair enough to say that when it comes to serious adverse events, we have, two bits of data, which I mentioned in the paper specifically, that I think provide, because they're replicating each other in a way, reasonable high quality of serious adverse events prevalence. Before I give you that figure, though, it's important to know that historically, from experts in pharmacovigilance data, serious adverse events tend to be, the ones that are reported tend to be only 10% of the true events. Now, of course, it's a different situation, different scenario. We don't know for sure what it is, but again, it's probably an underestimate, Gordan, okay? So the smoking gun for me in terms of reliability and good quality data is Pfizer and Moderna's own randomized control trials. So paper published in Vaccine a couple of months ago. I spoke to the lead author in detail, so I understand exactly what was behind that data. And what they found is the original trial that led to the approval of the vaccine, the risk of a serious adverse event, so something like life-changing event, hospitalization, disability, stroke, heart attack, whatever, the risk of that was higher than one being hospitalized with COVID. And this is during the original Wuhan strain, which we know was much more lethal. So that in itself is a big kind of red flag, right? So if that appears to be true, it's published in the journal Vaccine, peer-reviewed, it should be all over the news, I'll be honest with you. Now, that rate is about 1 in 800. So for every 800 people vaccinated, there's one serious adverse event. There is a caveat, however, is that some people would have suffered more than one serious adverse event, but they did some corrections, and it's still higher than the risk of being hospitalized with COVID. Norway has been pretty good and transparent in their reporting system, like the yellow card system we have in the UK, of pharmacovigilance data, where a doctor determined specifically in a subgroup of serious adverse events what was likely associated or likely to be caused by the vaccine. And their figure is 1 in 926 after 2 doses of Pfizer. It's very interesting, isn't it? It's quite similar, okay? But again, this is all in the first couple of months. So the problem is that we don't know the longer term effects. I very much hope, like you, I very much hope for myself, not just for my patients, that there's no longer term effect. But certainly we're talking of a serious adverse event rate of at least 1 in 1,000, 1 in 800. So the way I approach this now, and I'm very happy for people to challenge me, is if you're going to present the benefits or the harms in absolute risk numbers, you have to present the benefits in absolute risk numbers. And I've put it in that way. But the reason my conclusions of my paper said we need to pause the rollout to investigate the side effects is when it comes to drugs, when it comes to other vaccines, Gordan, this is unprecedented in terms of the reported harms. I cited 2 other recently, not in my paper, but recently on the media, I cited the fact that the swine flu vaccine in 1976 was pulled. It was suspended because it caused Guillain-Barré syndrome in 1 in 100,000 people. The rotavirus vaccine, 1999, was suspended because it caused a form of bowel obstruction in 1 in 10,000 kids, right? Okay. This is a rate of serious adverse events. We're talking about 1 in 800. And particularly the cardiovascular events seem to be one of the most prevalent. So for me, it's a no-brainer. In fact, there's not even a discussion to be had. The evidence is unequivocal on suspension.
Yeah. So I think something what is also very important to emphasize here is, yes, vaccines probably prevented some serious disease. But, even if something is preventing a serious disease and it is causing harm to people, some people, this goes against the basic principle of medicine, because if the virus is doing you harm, it's a virus, it's not under human control. But if you produce a drug and you give it to a person, especially without a consent. So my primary concern in this pandemic was that people were actually forced to take vaccine. So they didn't have a freedom of choice. Well, somebody say, yes, you can lose your job, you don't have to finish your university, but this is not the freedom of choice. And I had a discussion I work as a professor at the Faculty of Pharmacy, and we had a discussion about mandating vaccines to students. And I got invited there, and actually I lost because we mandated vaccines to our students. And one of the colleagues actually said, they do not have to study if they don't want to get vaccinated. No, I think this is blunt crazy. You cannot ruin somebody's career.
Yeah. Gordan, it's willful blindness. This is a behavior psychologically, I think, where in those people's minds, they cannot conceive, like I was briefly, that a vaccine could cause any harm. They could not conceive it. And probably, to some degree, I have found, even people supposedly very intelligent, was so terrified of COVID that it skewed, it stopped a lot of us being rational. A lot of scientists, I know, and you know this, Gordan, I'm sure you know this, are more emotional than people think they are in terms of their reactions to things. Over the years, I've done controversial stuff. I'm here for transparency and whatever, but controversial because I went against the narrative around things like sugar. I was called a quack when I was the first doctor globally, at least, after Robert Lustig, certainly in the UK, to say that sugar was harmful and we need sugar reduction. I had calls for retractions of my papers similar to that when I talk about saturated fat and cholesterol. And when you see the calls for retraction, some very eminent people are writing things that are completely false. And you realize that their reaction is not necessarily because they're being malicious. It's an emotional reaction. They're blinded by their emotions. So what is willful blindness also? Part of this is people turn a blind eye to the truth in order to feel safe, because it makes them feel uncomfortable, accepting something that they thought to be false, first of all, which is actually true, to reduce anxiety and to reduce conflict, and also to protect prestige. And in many cases, fragile egos. Let's have an open, honest discussion about it. We're all humans. We're all in those situations in our lives in different times. People often react because they want to protect their fragile egos. And this is absolutely true of academia, more than anyone. I've gone and spoken and given talks to some of the people who should know better, and a lot of them are just ignorant of the system failures. So, for example, I gave a talk on this vaccine issue briefly before I had my paper published to the, people want to understand the root causes of the problem. And I gave a talk at the British Medical Association conference, one of their fringe meetings organized by the Overseas Doctors Association. But all the big wigs from the BMA were there, the president of the British Medical Association, the chair of the British Medical Association. And the chair of the BMA was gobsmacked. His jaw dropped. He didn't believe when I said to him, do you know that the regulator in our country, like the FDA, we have the MHRA here, get 86% of their funding from the drug industry. He didn't believe it. This is a guy deciding policy on or influencing policy on vaccines. He didn't even know that. So as John Ioannidis points out in his paper, How to Survive the Medical Misinformation Mess, most doctors are unaware of the poor quality research that drives overuse of medications, underuse of cheaper medications or lifestyle, avoidable adverse events, missed opportunities for treating the right patient at the right time with the right medication, and waste, which is huge. Most doctors are unaware of the poor quality research that drives that. Just to give you a figure, 30 to 50% of healthcare spending in America brings no benefit to the patient. 30 to 50% of a $3 trillion industry. This is extraordinary. And then most doctors are unaware of the system failures of that poor quality research, right? And then even if they are aware, they can't critically appraise the evidence. And then they can't then translate that evidence into a way that patients understand. So these are all of the kind of root causes, if you like, the hierarchy that leads of information, misinformation, that then works all the way its way down into the consultation room or into the vaccine center. And as you said correctly, We're not giving people informed consent. We're not helping them make a decision for themselves. And they may decide. I have most of the people over 80 I've given this information to. People have asked, said, would you take the vaccine on this information? Said no, but one of them did. Said, yes, that's fine. Support them in that decision.
Yep.
But at the moment, separate to that, Gordan, the information on the harms, I've never seen anything like it. It's unprecedented. And our public health authorities, the chief medical officer here, and I'm speaking in Parliament soon, by the way, as well. So I'm not just somebody that's just blogging for the sake of it. I'm not here to draw attention to me. This is about the message, it's about doing the right thing. It's about going to the policymakers and shining a light on this information and putting them in a position, even if it makes them uncomfortable, to deal with it head on. And I will be speaking in the British Parliament in the next couple of weeks, date to be announced. And I'll be speaking to MPs. I had a discussion with I've gone straight to the chair of the Health Select Committee in this country. He's the longest serving Secretary of State for Health in this country, Jeremy Hunt. You may have heard of him. And I had email exchanges with him. I met him. I said, this vaccine needs to be suspended. And he said, which vaccine? And he went red when I said Pfizer. He thought I was going to say AstraZeneca. He said, email me. I gave him an exchange. We had exchange emails, very polite, very good, very friendly guy. And then he was on holiday, and I sent an email to him again. And his special advisor came back to me, said, Aseem, thank you for sharing these findings with us. I think it's a good idea that you'd contact the regulator with your concerns. The regulator who's getting 86% of their funding from drug industry.
I think
people need to know the truth, Gordan. They
So
need to know the truth.
So I think something which is important to emphasize over and over again is the level of profit which actually Pfizer made. And when you compare it to what AstraZeneca did, because AstraZeneca signed a contract with both British government and EU that during the pandemic, they will sell the vaccine for the cost price, which was 1 point something euro. While the Pfizer and Moderna are selling the range of 20-25 euros per sample. And there were some published estimates that over 95% of that is a profit. And of course, there was an investment in research. So maybe initial couple billions were used to reimburse the research costs. But so far, it's over 100 billion euros, which have been paid to these few companies, which is now pure profit. And if we think now about this new Omicron vaccine, I think the US paid 10 billion for the vaccine. And I think the uptake is 3 to 4% because even Americans don't want to take it anymore. So some public official made a decision to give $10 billion of our money, of taxpayers' money, okay, of Americans' taxpayers' money, but we in Europe also pay to the producers, billions, which people don't want. And I always wonder, is anybody doing a proper investigation about where is this money moving, and is there something illegal behind these decisions?
Yeah. So Gordan, I think you're absolutely right. I think the problem is the laws that have allowed this to happen themselves, the regulator being funded by industry, the fact that even in America you've got lobbying and political parties can take money from the drug industry. Those themselves are unethical, unjust, and undemocratic. I'm a proponent. I believe in real democracy, informed democracy. We don't have that. This is a symptom failure of the fact that we are seeing, in my view, this is the beginning of the collapse of corporate capitalism. This is the beginning of the collapse of unchecked power increasing by entities that are psychopathic in their nature. They are money extracting machines, and this is what we're seeing now. And the fact the population are turning is the beginning of the end of this. We need to rebuild. We're not just fighting for people's health here. We're actually fighting for democracy, for real democracy. And more and more people are becoming aware of that. These organizations, through capturing governments, through capturing the media, are suppressing free speech, suppressing information. And therefore, they need to be discussed as when anyone talks about the pharmaceutical industry, the first thing that should come to their mind is enemy of democracy. Enemy of democracy.
And can you maybe
psychopathic in its nature? And this is how we change the narrative. Very simple thing.
So
everybody needs to know that. When everybody knows, Gordan, then you get the revolution that we need.
yeah. So maybe you can also comment on a similar situation with the food industry and the sugar
Yes,
versus fat. How all this
absolutely.
started?
Absolutely. Well, big tobacco, right? So, you know, if people want to look at the history of it, it's fascinating. There's a great paper by Kelly Brownell, professor of psychology in the United States. It's called Big Tobacco Played Dirty and Millions Died. How similar is big food? And they talk about 50 years from when the first links between smoking and lung cancer were published, before any effective regulation was introduced to curb tobacco, consumption, because big tobacco adopted a corporate playbook, a dirty tricks campaign of plain denial that there was a link between smoking and lung cancer, confusing the public, buying the loyalty of bent scientists, okay, and planting doubt. And that's how they managed to avoid any regulation. And the denialism was so extreme, Gordan. In 1999, the CEOs of every major tobacco firm went in front of US Congress and they swore under oath they did not believe nicotine was addictive or smoking caused lung cancer. That's psychopathic as far as I'm concerned. There's no other reason for it, okay? And what we see is, you're absolutely right, big food, big pharma, the same corporate playbook is being adopted there. And I've studied this in a lot of detail, and I can see it happening. When you see the evidence and you see what's going through the media and you see through spokespeople, they're adopting a very similar type of tactic in their speech. I figured out, for example, I won't name the organization now because I made up with them because I called them out. But let's just say one very prominent health organization that was responsible for helping people with diabetes. When studies started to emerge linking sugary drinks with diabetes, for example, I looked at the newspaper reports, and the spokesperson from the soft drinks industry, the sugar industry, he would say one thing, and the spokesperson for this charity that's supposed to be helping patients said something almost identical. So I went on their website, and I found that they were taking money. One of their sponsors was a very big sugar producer, sugar manufacturer. And I called them out in the BMJ. They weren't very happy about it. But this is the same sort of thing all over again. So unfortunately, many of these organizations that and I want to trust them, and we need to rebuild them. My paper talks about policies moving forward. The drug companies can develop drugs, but there's no way in hell we should let them test them anymore. And we certainly shouldn't be allowing them to hold on to the raw data, which we still don't have even on this vaccine, right? So people can't independently analyze their methodology, scrutinizing the results properly in terms of benefits and harms on individual patients. All of that will come out through the raw data. Universities, I mean, any medical education shouldn't be sponsored by the drug industry, for example. Certainly in America, politicians shouldn't be allowed to take money from the drug industry or political parties. So this is what we need to do. We need to disconnect. It doesn't mean we don't need the pharmaceutical industry. Of course, we need these industries, but we need them to be making money doing the right thing. And unfortunately, the default, because of laws and unchecked power, basically means they have started to make money doing the wrong thing. And it doesn't take a rocket scientist to work out that if you have so much power over so many people, and come back to the evidence-based medicine triad, if you're making clinical decisions on incorrect information, you're going to get bad patient outcomes. And that's what we've got.
Yeah. So maybe we can go back to the risks of the vaccines, which is something we all have to be aware of. There is nothing which is risk-free. And I think it's important for everybody to able to get the knowledge about the real risks and the benefits and to make their own decisions. So we haven't touched the risks of the vaccine so far. So what did you conclude in your research?
Yeah, so it's interesting, Gordan. I wasn't aware, and I'm sure many doctors aren't aware still, and this was quite shocking when I found it, through that original vaccine paper that was a preprint before. The World Health Organization, interestingly, they endorsed a list before the vaccine was rolled out of potential serious adverse events that could happen with the vaccine based upon 4 bits of data: COVID itself, animal studies, the mRNA technology, and the fourth one was harms from other vaccines. And they made a list, and I looked at it and I was like, wow, the cardiovascular complications, essentially every organ system, Gordan, the brain, the heart, the kidneys, the liver, the ovaries, the testes, every organ system essentially is affected potentially. That risk in terms of serious events seems to be about 1 in 800. However, in terms of what's been reported in the UK, we're getting figures of 1 in 120 in terms of people, something more than mild that they experience. And I suspect in terms of overall adverse events that are quality of life limiting, not life threatening, but quality of life limiting, at least for a period of time, I suspect that figure is probably much, much closer to 1 in 100 than it is 1 in 800.
So if I remember correctly, it was close to something like 6% of people requiring help after vaccination.
I know, it's crazy.
It was published a few days ago, right?
It's crazy.
Okay, so we have to be.
But I don't want to compare apples with oranges. So I think if we're saying preventing COVID death, it's still not exactly the same. The best we have is preventing, in terms of serious adverse effects. But I think the fact that the COVID death prevention is still very modest in itself will surprise a lot of people. And I think one thing people should know and fully understand now is that certainly the vaccine doesn't, whether it was true in the beginning or not, we don't know, but it certainly doesn't prevent transmission anymore.
No, it doesn't.
So therefore, you're not helping anybody else. You're not helping your grandparents if you get vaccinated. You're also not protecting yourself from infection.
Yeah. And I think another important thing.
You're only potentially protecting yourself from serious illness and death, not even infection. Yeah. So, I think that and of course it depends on your age and all that kind of thing.
Yeah. And I think another important thing to emphasize is that now through media we can hear that, even against influenza, we are getting vaccine every year, and why should we take a new one against COVID every year? But this is very different because influenza has a segmented genome. It recombines every year, and practically a new strain comes every year. And we are
Having said that, though, Gordan, and please correct me. You may know this data better than I do, but the data I've seen on the flu vaccine isn't very good either.
No, it's it's very inefficient.
We had a publication in BMJ recently, I think, a few years ago, saying there was no benefit from the flu vaccine in over 65s.
So it's not really clear. There is a different data. There is some data showing even long-term cardiovascular benefit. But what I wanted to emphasize here is that for the influenza vaccine, the World Health Organization is trying to predict which strain is going to circulate and then use the vaccine for that strain. Sometimes they sometimes they make a mistake, but nobody is proposing to take the same vaccine for the strain which does not exist anymore. Like until recently, we were taking the Wuhan strain, which does not exist for 2 years.
I know.
And just giving a new dose of the same virus as a vaccine, it doesn't make sense. So I was actively promoting.
It's called a miscarriage of medical science, Gordan. Yeah. The greatest miscarriage of medical science I've ever witnessed in my lifetime, and maybe we'll all witness in our lifetime. Yeah. Let's call it out for what it is. It's nonsense. Yeah. And none of the people on the other side, and I've had direct communication with people who are speaking to people in the FDA, have anything to say to rebut this stuff. They're just in denial. They're carrying on what they're doing. They're not addressing these concerns head on. They're ignoring the side effect data, which is clear, right? These serious harms exist and they're not rare, and they're ignoring it.
Yeah. Okay, so we are talking for 45 minutes already. I think we have tired most of the people.
We've exhausted the data, absolutely. Yeah. But I would encourage, Gordan, people to read the papers because I think that will be helpful to understand what's going on.
I think what is also essential that researchers, medical professionals, they try to read the original data, read your paper, and not just follow the propaganda we hear in the media and through the medical representatives, because something which we didn't say, and I think it's important to emphasize, and I tell it to my students each year because I teach at the Faculty of Pharmacy, and many of my students will become medical representatives. And medical representatives are the main source of medical information for many physicians because people don't have time to read all the papers.
Of course.
And there is a huge responsibility on the shoulders of these people to convey the objective information, which goes against their private interest, because if they sell their own drug and claim it's the best drug, they will make more money. Yes. And this is a really complicated situation. And we also had some kind of criminal activities in that field, and you know, some medical representatives would not even they would do illegal things just to convince people to do something. And I also see in the media people publicly claiming things which are simply not true.
Yeah.
We had a media campaign still in Croatia saying that you have to vaccinate to protect others. This is not true.
Yeah.
You know, it doesn't matter how many times
This is
you take
failure
a
of
booster.
Gordon, it's failure of government, though. It's failure of government. Government isn't doing their job properly.
Yeah.
That's the problem. I think that people need to understand that, and need to and to make those politicians and those policymakers accountable. But the only way you can do that is by disseminating the information. The challenge we have, Gordon, is a lot of the information you said correctly through the mainstream media is false. Therefore, people are being given false information and making decisions on false information, or incomplete information at best. You know, so that's the challenge. But things like this, these discussions, you know, I think the power of the sword of truth is more powerful than anything else. And it just takes a few people to start a movement, and it grows. And then, you know, we revolutionize the system. So it works for the interests of the patient and the public, right? We are here, ultimately, we're here to help improve there's a great definition by the WHO of health, which is a state of complete mental, physical, and social well-being, not merely the absence of disease and infirmity. So we are champions for health, and we need to keep fighting, and that's what people want. Everybody, the most important thing for people in life is actually their health.
Okay, so thank you for leading the fight. It was a pleasure chatting with you, and I will put this recording on YouTube. Hope they will not take it out.
Lovely. Just choose a clever title. You'll be fine.
Yeah. And we keep fighting. Okay.
Right, my friend.
Thank you. Thank you very much for your time.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye.
And thank you everybody for being together with us for the 45 minutes. I will